talked earlier about unmet psychosocial needs. A typical quote would be, so many of my patients nowadays have mental health or substance use problems. What am I supposed to do when they can't afford care but don't have a proper place to live? I think all of us physicians are beginning, in that we're seeing what's really going on in terms of the ability to afford and access care. We kind of throw up our hands and say, well, I'm not a social worker, I'm not a care manager, I don't know about all these programs, how are we supposed to respond? I realize it's important. It's even more so for the subspecialists who, again, may have only a short time that they are involved with the patient. So I think as a subspecialist, I would begin to communicate with my primary care referring doctors the importance of them beginning to do pre-visit risk assessment, and even providing them with some of the tools that are out there, ways of looking at complexity, screening tests for mental health problems, disability scales to help get an idea about the impact on people's lives of various of their diseases. So the subspecialist can come to our primary care practice and give us some ideas about ways that we could help stratify patients to get them the best care. A patient coming into a subspecialty practice who already has had this kind of risk assessment is going to get better care because the subspecialist can give them different levels of intensity depending on what their needs are, and can also make sure that they are following through on their behavioral health treatment, following through on their smoking cessation program, seeing the community agency about housing problems. So there are a number of ways that you can suggest to subspecialists to get involved in care management. Again, we know that in primary care, particularly with the patient-centered medical home movement, that we're asking FQHCs to have their own community-based care management teams, but subspecialty groups are unlikely to have people with those kinds of skills. On the other hand, they can connect to the primary care practices that do. So they can also use hospital health system and payer programs of care management for referral, recall, and appointment services. You don't have to pay for those services within your practice. You can use them because they're already being provided by the hospital and payers. You can contract with the behavioral health organization for services. I know that's being done in some of the bariatric treatment programs. I know that the cardiothoracic surgeons, based on recent studies, are making sure that all their patients are evaluated and treated for depression in order to have better outcomes. They can use telepsychiatry support. There's a program called TIPS in our region that allows you to call a pediatric psychiatrist at any time and get help or refer a patient through them. You can develop and maintain your own care management team. Again, we mentioned CCM coding, grants, performance payments, and shared savings. Some of the subspecialists in cancer, in kidney disease, in rheumatology could have so many chronically ill patients that they could run their own care management team focused on subspecialty knowledge in those areas, and they can get paid for it through some of these methodologies. There are some outside chronic care management services that can be that you can pay for, again, through CCM coding. And again, there are some hospitals in our area that are developing care management programs for their own practices, which involve nurses, pharmacists, and even outreach workers.